Hello, I'm Donald McCauley and welcome to medicsvoices.com, where we talk to the key opinion leaders in health and medicine around the world. Today we're in London and I'm talking to Matt Harris. But Matt, you've extensive experience right around the world. Tell me a little bit about your current role and how you got there.
So I'm a public health consultant in the NHS. I'm a consultant in public health medicine here within the Imperial College Healthcare NHS Trust, and I'm a clinical senior lecturer in public health medicine. But I didn't really set out to do any of those things, which is often the way, isn't it, in clinical careers. I qualified in medicine a long time ago now, in the late 90s, and for one reason or another, which I won't bore you with, but I ended up moving after my house jobs. I ended up moving to Brazil and re-qualifying in medicine there. So I learned Portuguese and from scratch, and I had to pass their exams in the medical school exams at the University of Sao Paulo in order to become a Brazilian doctor. And then I went and worked as a GP in a rural area, super deprived, extreme poverty in the northeast of Brazil. So there was, you could probably picture it, houses made of sort of mud, and there was no sanitation and no electricity. I had to get 4 buses to arrive there at work, and I was running a single-handed GP practice with 5,000 residents in my list for about 4 years. I then moved into public health, returning back to the UK. From there, I went and did my master's in public health at the London School of Hygiene, and then worked in sub-Saharan Africa for a year or so with WHO, and running an HIV hospital as well in central Mozambique. And that's really what moved me more into public health space, thinking about the big picture, thinking about population health, and thinking about policies rather than patients, so to speak, in terms of clinical care. I did my PhD at Oxford University shortly after that, and then entered the training program to become a consultant in public health. And that's what's brought me to where I am now.
Well, let me bring you back to Brazil, because you paint a picture of poverty and a health service that was really very basic. But what struck me was, in Brazil, there have been incredible steps forward in medicine, particularly in primary care, inspired by a previous government. Tell me a little bit about that.
It's a fascinating story, actually, I have to say. And my experience as a GP in their system actually then inspired really the rest of my work, which I can go into later. But we've done a lot of work over the last 20 years, bringing elements of their primary care system into the NHS, particularly around the role of community health workers. But they didn't have primary care before the late 1980s. I mean, the primary care that they had was essentially walk-in clinics. It was mostly if you could afford it, or you'd show up at A&E. There was no sort of structured primary care service in play. But then at the end of the military dictatorship in the late 80s, they underwent a radical social and political and economic transformation into a liberal democracy, but that also put health right at the center of its constitution. So they created for the first time a unified health system that was the responsible, they call the SUS, the Sistema Único de Saúde. It's a unified system, a bit like our NHS, in the sense that it was taxpayer funded. It was under the government's responsibility to provide healthcare, particularly primary healthcare, for all citizens, free at point of use. And that was really a radical transformation at that time, based on the system or lack of primary care that they had prior to that. It was really part of a big social movement to make sure that citizens and residents all had access to care. It's actually largely inspired by British GP system to a large extent, because they then really wanted to develop this idea of family medicine, which they didn't have previously, and also the mix of the Cuban system as well, which was a big influence. But what they did really well, I think, was leverage community assets in the form of community health workers in underpinning their primary healthcare system. So they deployed at pace. It's remarkable the speed with which they've created this system. They have essentially a primary care healthcare unit that's just composed of a GP, single-handed GP, a practice nurse, and a nurse auxiliary, and between 4 and 6 community health workers, all recruited from the local area. But what's really interesting is those community health workers, they're residents in the areas that they then also serve. So they're recruited from that community and they allocated to a micro area of about 120 to 150 households, with no overlap or gaps between those little micro areas. And they're just mandated to visit every month the households within those areas, just to check in on people, find out how they're doing, build those relationships and that trust, whilst at the same time working with the primary care team very, very closely. So they essentially they are the ears and eyes of the GP and the practice nurse out in the community. Now they've scaled, as I said, the system throughout the whole country, and that model of primary healthcare is now serving something like 75% of the population across 95% of the municipalities, and it's seen some extraordinary outcomes in terms of population health. So over the last 15 to 20 years since it was beginning to scale, municipalities that have a high penetrance of this model compared to those that don't, all things being equal, have a 34% lower cardiovascular disease mortality rate. So that's pretty extraordinary. But when you understand what the community health workers do, you can begin to see the reason why. You know, they spot diabetes and hypertension early on. They refer people in for testing early on. They talk about healthcare all the time. They have help people stop smoking, reduce weight loss, physical activity, all of those interventions that we know promote health and well-being and have important outcomes downstream. They're doing all the time with all their residents, and not just on cardiovascular disease, also on mental health, depression, child health, immunization uptake, screening uptake, whatever it might be. They're intervening, they're giving advice, they're signposting to all their residents all the time. So those, if you like, upstream interventions that are very low technical level, don't require a highly qualified individual to do, has really led to some important shifts downstream. So you're absolutely right. I think the Brazilian system has been phenomenal, not just because of the holistic, comprehensive manner in which the community health workers work, but because of the extent to which and the speed with which it has scaled across the country.
Let's change continents now and talk about Mozambique. Tell me about your experience there. I don't think primary care is nearly as developed as Mozambique. I think you described more a public health role.
Yeah, so I'd say primary healthcare, at least in the days when I was working there, it has been a while since I was working there, but primary healthcare wasn't like it was in Brazil or here, of course, here in the UK. You know, I think the clinics, which were much fewer and further between than certainly here in the UK, were serving probably in the region of 10 to 20,000 people, maybe even more. They would be staffed by maybe a junior nurse with a doctor visiting every now and again type thing. So a very different type of approach. Things may have changed since then. But I was running an HIV day hospital, which was PEPFAR funded and was located within the regional center of excellence, so to speak. So a big tertiary hospital. And it was quite an interesting time, because essentially the HIV, if I'm not mistaken, the HIV prevalence at the time was probably higher than diabetes is here in the UK. But of course, you manage diabetes predominantly in primary care, whereas HIV in Mozambique at the time was being managed in a vertical fashion. So you could only get your HIV treatment or monitoring in this day hospital, which was very distant from where most people were living. So one of the roles I had to do at that time was to try and decentralize HIV detection and monitoring and adherence to heart treatment out into the primary care clinics, which meant upskilling some of the more junior nurses that were staffing those clinics in how to support adherence, how to distribute the medicines out into the community, etc., in order to alleviate the pressures on the day hospital.
Lots of this work that you've done seems to fit in very nicely with your Harkness Fellowship. Tell me how that worked.
The Harkness Fellowship, which, by the way, if anyone's listening, is phenomenal, and I highly recommend anybody to do it if they can. So the Harkness Fellowship that I did was all about reverse innovation. So very much speaking to this idea of what can we learn from low or middle income country contexts that can be adopted into high income country healthcare settings. And in that fellowship, I was based at New York University. My mentor was Professor James Macinko, who's now at UCLA, and Dr. Don Goldmann, who's the Chief Scientific Officer Emeritus at the Institute for Healthcare Improvement. And we were starting to look into what some of the challenges and barriers are to adopting innovations from low-income countries. These aren't settings that we typically pay a lot of attention to. The types of innovations that they produce don't have the sort of bells and whistles and level of sophistication, let's call it from technologically speaking, that some of the innovations that we often use here in the NHS might have. They innovate what we call frugally, doing more with less, probably out of necessity, possibly because it's just a mindset. And then, of course, there are all these, what I would call colonial reasons as to why we're not paying attention to those settings that get in the way. So the Harkness Fellowship started, for me at least, it began my research interest in this area. We did a sort of a pilot survey where we asked people in the US to rate abstracts online, and we fictionalized their sources to either high-income countries or low-income countries, and we found that there was a strong signal to suggest that those people that were rating abstracts from a low-income country rated them far worse than those when same abstracts were listed as being from a high-income country, which sort of corroborated, if you like, our sense that when things come from a low-income country, there's just an additional challenge. There's something else that you have to get over in order for those innovations to become palatable to clinicians within the UK and the US, and that really has spawned a lot of other research that we've done since then.
And that brings me to your recent book, because it includes a lot of those innovations. Tell me a little bit about the book and just go through some of the titles of the chapters, which are really fascinating.
Oh, thank you. Yeah, so the book just came out last week. So this is hot off the press, very exciting. It's called Decolonizing Healthcare Innovation, Low-Cost Solutions from Low-Income Countries. And what I try to do in the book it's essentially in two sections. I'll start with the second section and then come back to the first. So the second section essentially invites the reader to explore 6 frugal healthcare innovations. And there are many more than these, of course, but these are just ones we had space for, and where they've come from and why they're appropriate for the NHS. So I'll give you some of the examples. I look at the use of mosquito net mesh for hernia repair. Now, mosquito nets, as it happen to be made of exactly the same material as the commercial mesh that we use for hernias here in the NHS, but cost something like 10,000 times less. So there's, a really significant cost imperative for us to use that mesh, and it's being used at scale in India and throughout sub-Saharan Africa for hernia operations, because of course the expensive commercial ones, which are pre-cut and pre-sterilized and single use only, of course, and pre-packaged, are prohibitively expensive for those settings, so they've adapted. I discuss in that case also the clinical effectiveness, and head-to-head clinical trials have demonstrated complete equipoise and complete equivalence in terms of adverse events, infection rates, relapse rates, having recurrence rates between commercial mesh and mosquito net mesh. That's just one example. Another example is a device called Saiba's method, which is for postpartum hemorrhage. Now that's essentially, it's a condom tied to the end of a urinary catheter, and you inflate the condom with saline, insert it into the uterus when there's some postpartum hemorrhage occurring, inflate it with saline to exert pressure within the uterus to stop the bleeding. It was invented by Saiba Akhtar, a Bangladeshi obstetrician, about 20 years ago. And it essentially does exactly the same job as the balloon tamponade devices we pay for here in the NHS that cost about £300 each. But of course, tying a condom to the end of a catheter is cheap as chips. So it basically costs nothing. And the studies seem to show that actually the outcomes are identical, in fact, slightly better using the condom and catheter device. Another example is, and I'll stop here because there are many more to go through, is the use of tilapia fish skin from Brazil. This is a fish that's found throughout the Amazon. People eat it routinely. It turns out that if you use the skin of the tilapia fish, which is very, very rich in collagen, I think 2 types of collagen, you can place it on 2nd and 3rd degree burns, the serious ones that otherwise you'd need to use skin grafts for, and it leads to a very rapid re-epithelialization of a short duration of time, less pain, less infections, less need for bandage changes, and only costs $11 for a complete course of treatment. Now, There are technologies using fish skin available in the NHS, but they're acellular fish matrices that are bioengineered and cost about £1,000 for a segment about this big, the size of your iPhone. So there's a clear cost imperative again in that case, in the case of plastic surgery, and the list goes on and on and on. You know, there are all of these adapted technologies using the resources available around them, where clinicians have sort of improvised, but that turned out to be as effective as the technologies that we sort of overly engineered here in the NHS, and that cost a lot more at the same level of effectiveness and safety. So the business case, if you like, is very, very strong. But then it comes to the first half of the book, which explores some of the colonial reasons why we're not paying attention to those opportunities. And there are many of these things, and it's all to do with the fact that, you know, in some senses, clinicians like sophisticated technologies, but also that our gaze, let's call it intellectual gaze, is very much towards the West. It's a Eurocentric or North American gaze, where we predominantly pay attention to those institutions in those countries, somehow arguing that those contexts are more similar to ours here in the UK. But these are very woolly reasons. All countries are equally different to each other for all sorts of reasons. So our preference to pay attention to the North American setting or European setting for inspiration is actually one that's rooted in what we would call white Eurocentrism, that is itself very much rooted in coloniality, because Western medicine emerged at a time of colonial capitalist expansion in the, I suppose, in the Middle Ages, sort of Enlightenment and Renaissance periods. And it's therefore it's a mindset approach where we have to sort of understand that we're missing opportunities to adopt or learn from countries that are doing far more with a lot less, simply because we're not used to doing that. So the book is really about how to decolonize healthcare innovation. It's about what can we do clinically, what can we do in higher education when we teach our global health students and public health students, what can we do to address some of these imbalances in knowledge exchange, in the way that we teach, in the way that we understand how innovations really work, in order to find some of those opportunities and leverage them.
It's been fascinating talking to you about this. Let's call it reverse coloniality. I think it's wonderful to hear your wide international vision of what we can do. It's always a pleasure to talk to you. I can't think of a greater contrast than your title as public health physician. Matt, thank you very much indeed. Wonderful as always.
Thank you. It's been a real pleasure.